Hello, everyone, and welcome to the Quorum podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric. This week, we are in Pavia at the University of Pavia. We're running our Austere and Prehospital Ultrasound course, and with me are a few of the students. So if you guys couldn't introduce yourselves.
So I'm Jonathan. I'm a 6th-year student in the University of Pavia, studying medicine, originally from Israel.
My name is Ron. I'm a colleague of Jonathan. I come from Israel, and I'm a 6th-year medicine student here in Pavia as well.
I'm Teo. I'm from Turkey. I'm a 5th-year student in here, medicine.
I'm Tongi. I am a BSc student and currently in my third year, and I live in New Orleans right now.
So you guys are here taking our ultrasound course, and I was quite taken aback to realize that you all are teaching ultrasound. And Professor Enrico did not bother to let me know that. So these 2 days have been kind of a flipped classroom. So tell us about your experience using the CoROM way of ultrasound.
So we've been teaching ultrasound for quite some time, mostly for third-year medical students, just starting their the clinical part of their education. And for first-year students who have no clinic background, so just anatomy-based. And I think that your approach to it is the fact that it's very practical and actually comes from the ultrasound towards the medical side and not vice versa. Actually makes a lot of sense because especially in the EFS protocol, the way that you teach makes more sense than the way that we've been taught. Also, the home-based approach, even for us, and the guys can correct me, but it actually fixes the way that you scan. So you don't get lost, you don't get sidetracked along the way. And I think I'm going to take a lot of stuff from this course to the way that I'm teaching later this semester. So I'm very happy about it.
I totally agree, especially the finding the home idea was amazing. I don't get lost in it. And sometimes while we scan, we think about the disease, physiology, etc., but we miss the real picture. We miss the big picture. We get lost in the details. And with the home technique, we don't do that anymore. It was amazing.
So I think this is the 4th or 5th ultrasound course or seminar that I attend. I think at this point, scanning-wise, I am pretty proficient. This was the nice part about this course where it was kind of more peer-to-peer, teacher-to-teacher. I did learn a lot. I did learn and improve my ultrasound skills 100%, but more than that, and more importantly than that, I would say that I learned how to teach or present topics in an easier way to understand. And like Jonathan said, your approach is based on everybody can pick this up. Everybody can learn this. And that's what I really, really, really liked about this course.
So coming from the aspect of just getting things done and quick pictures into more of a CoROM sense of the term and taking a bit more of your time and just really reviewing the basics and going back to it has been really useful. And it's been super, super useful bouncing, the smaller questions off of you guys. Like, when I was initially taught, it was just, here's the liver, here's the kidney, and just look for some black stuff. And it's been super cool to be able to bounce some ideas off of you guys about like the small minutia that I really haven't had any experience over.
So you teach ultrasound as an anatomy tool for first-year medical students. Tell us about that experience.
So I would say, we started a couple of years ago with an elective course that we have here in a medical program. It's a course open to everybody, but most of the people who take it are first years. So the only knowledge they have is anatomy. And what we do is we try to run it in parallel with the anatomy program. So when they talk about splanchology, when they're reviewing systems, we try to be as parallel to that as possible to contribute their anatomy studies. This upcoming year, we're going to change things up a little bit with this program. But other than this, we have a program which we call Ultrasound Fridays, where everybody can come and scan from the medical faculty, no matter which year you are. We have about 12 to 14 tutors right now. We have 5 rooms, 5 machines, which we can use, and then we go through the different systems.
Just in the context of anatomy, I think that ultrasound has a huge advantage over any way of teaching. It's not a textbook, which gives you some sort of representation, but it's not the real deal. We unfortunately don't have access to cadavers in Pavia, so this is the second best thing. It's dynamic, they breathe, everything moves. You turn them on one side, everything moves to that side. So they really get a sense of anatomy as a living, moving, dynamic thing instead of just reading the textbook and answering multiple choice questions. So they actually, as close as they can get to feeling the anatomy. And our experience was that once they actually scan, they understand the textbooks better. They understand the relationship between the organs better. Everything connects. So it is really an amazing tool for that kind of stuff.
It also shows a lot of variations in the anatomy. It is an important thing because when we study it from the textbooks, we only see the perfect, most common anatomical structures. But this is not life. You will have patients with different anatomical orientations, and the students are seeing that too. From the first student, we find the heart pretty easily well-oriented, but on the second one, it takes a while for us to find the heart, get a better image quality, there's too much gas, etc. The reason behind that is because we are not all the same. We are not textbook people.
You would have a very interesting article if you would put together a Delphi study, a pre-post Delphi study on how students felt comfortable with the anatomy knowledge before you taught the ultrasound and compared them to the people you have taught, and you'd see hopefully a increased learning outcome. Have you thought about that?
So yeah, recently, actually pretty recently, we got into writing and publishing. Our goal in the end is to set a standard for teaching, because right now it does not exist. For medical students, what does a medical student need to know when he graduates in terms of ultrasound? Because this is a tool that is it's skill-based and it's not knowledge-based, right? Anybody can learn it. It's not difficult. Most of the specialties use it. In your clinical rounds as a student, you will see it. So right now we wrote an article about our experience and what we did here, a little bit of the numbers and our methodology, our syllabus, very, very basic. From here, we will take it so we did collect data in the past couple of years with feedback forms about how do you feel with anatomy before and after coming to the scanning sessions. And this is going to be our next article. Other than that, we are looking into, so Jonathan will tell you more about it in a second, but we're looking into ways of peer-to-peer teaching, because this is what we're all about here. Because we believe it's superior to professor to student teaching, based on personal experience and based on the experience of the medical students around us. So we are diving deep into ways of peer-to-peer teaching, because there are different schools of thoughts. There are different ways we can approach this. And we have a pretty big bank of students who take our courses, who come, who scan. So we do have that ready. And Jonathan will tell you more about the peer-to-peer approach.
Yeah, so we've scaled up this operation from the first year. It was just me and Ron scanning 200 students, teaching 200 students. And last year we had between 200 and 300 students. I don't remember exactly, but we had 8 tutors. This year, hopefully we'll scan almost everybody in the faculty, because we have 15 tutors after the upcoming course with Professor Brunetti. And the main question is how to teach, because you get new people on board to teach. There is the issue of skill, which is easily solvable. They take a course, they come to the clinics, they scan with doctors. But then the main question is how do they transfer this knowledge and skill to other students? So today, this is our main dilemma. So we're going to plan is to run a couple of parallel groups and to see what's the best way. Is it more teacher-centric or student-centric? The radiologists in our hospital do hand over hand. So basically, you just sit next to a radiologist. He holds your hand and the probe, and he moves you around the abdomen. So we're trying to figure out what's the best way to do it and the most efficient way, because unfortunately, what we do is kind of underground, not fully in the curriculum yet. So we need to demonstrate to the system that it should be done. So right now, we're trying to establish how it should be done, to who it should be done, and what exactly should be taught. So this is the main challenge of this upcoming year.
So there's another publication article for you, a homegrown grassroots option for peer-to-peer teaching. You could look at outcomes from before you set up this peer-to-peer network and after you set it up.
Yeah, absolutely. And now we have students that have started the third year that had the course with us. And the most thing that I enjoy seeing the most is that now they are signing up to ultrasound courses because they got exposed to this tool. Now they want to keep going. And the more that they be exposed to the clinical aspect, it enhances their study experience in class. Because now when you say, yeah, you use ultrasound for something or use any tool, they have this window to explore that tool, or actually even go online and check how it looks like. So we go from the textbook to the clinic through those tools. And we see a lot of students that want to be more involved in clinical teaching, going to the hospital during the second year, even before they should go there. And I truly believe that this ultrasound experience, which we do in the hospital, actually in the clinic and not on the faculty, on campus, really expose them in a very early phase to the fact that they're going to be a medical health provider. They're going to do these things in real life. And it really brings everything closer to home than just reading the books, answering questions, and going through the motion until your third year and going through our clinical rounds.
So the University of Pavia is supporting you. They're giving you classrooms to train in. They're giving you 5 machines.
So the hospital supports us. It's kind of funny because always when you start talking about ultrasound, there's this turf war between radiology and everybody else. So we are now right in the middle of this turf war. Right now we are scanning and not on university facilities, but on the hospital facilities, thanks to Professor Bonetti and Dr. Poma. But this is our proof of work. So once we start publishing, and this year we have more professors that are exposed to our project, slowly we get more into the ski lab and into other classes, and more professors wants to do workshops with us. So we organize everything. They just come and teach ultrasound in gastroenterology, ultrasound in vascular surgery. And we think that this is the way to get it integrated into the curriculum, which is something that is not done in Italy at this point, nowhere. But here we have an actual opportunity to get this thing into the curriculum and keep it going for as long as it will go, basically.
So basically, you were going through your medical school curriculum, and as you're going through, you saw a deficit of ultrasound. So you took it upon yourself. It's just a group of you came into the hospital, and you said, by the way, we're going to use this ultrasound machine, and we're going to start doing this every Friday.
And the hospital is very accommodating. Once the patients are done, around 4 p.m., we have the place for ourselves. And we have very good support from Professor Brunetti in all of the... He tutors us. He makes sure that we do the right stuff. He pass everything by here. So it's not just a bunch of students scanning. Actually, everything is based either with professors or literature or courses that we've taken. But it's a growing movement, and it's really nice to see how more and more people want to get involved.
So ultrasound is so much a hands-on sport that you can look at all the videos on YouTube or Nicora or any of these apps, but until you get that head knowledge into your hand, it's just not working. My first ultrasound course a decade ago was the Royal College of Emergency Medicine 2-day course in London, and it was a whole bunch of PowerPoints, and we got around the live casualty. There was 8 people per probe, and it was literally 15 seconds. Oh, you see the gallbladder? Okay. Oh, you see the gallbladder? Okay. You see the gallbladder? I didn't learn anything. I learned not to go back to that. And you guys have sorted that out. You guys have looked at this and said, we need our fellow medical students to have hand knowledge in ultrasound.
Definitely. So my first time touching an ultrasound machine, and I think it's the same for the guys as well, was in my first year medical school, and it was pretty much what you described. So we were 10 people with residents stuck in a hot, sweaty room, and not all of us got to touch the machine. So most of us just saw, but even when you did get to touch the machine, it's a hand on hand. So you learn nothing. You don't get excited about it, and it's not something that appeals to you. So what we do is we have 1 tutor per 4 students. This is what we found based on literature and our experience as the best option. And other than that, I can cite you about a dozen articles that talk about peer-to-peer teaching and how much it's how superior it is to other methods of teaching, especially in clinicals, in the clinic, and especially with ultrasound.
So where did the original ultrasound training come for you guys?
So we got exposed to it. I didn't have it. I had COVID in my first year. So the country was shut down. So we didn't have this lab. But I think that we stumbled upon it while doing rotation with Professor Brunetti in the infectious disease ward. And he mentioned to us, hey guys, they have this course. And it just rolled from there, basically, because ultrasound is a game. If you do it peer-to-peer in a good environment, it really feels like a game. So it's a good place to explore it and try things, and you're not being scrutinized, and there's no radiation involved, and it's basically free except for electricity and the gel. So it was a good place for us to really get confident in touching other patients or people and learning anatomy, physiology, pathology, and so on. And it just kept growing from there. We just seized the opportunity, and we saw that it's working, and we're having fun teaching, and we're having an impact on our colleagues. And it just kept growing. I think one of the stuff that we do better than traditional teaching, because we are students, so we know what's boring for us and what's interesting, is that we do almost everything in either fully reversed classroom or almost. So we don't give long lectures. We used to give a 25 minutes lecture about the physics of and knobology of ultrasound. which was basically, guys, you don't need physics. Don't worry about it. You just need to learn the motions, movements, and that's it. And nowadays, every time that the student starts the ultrasound course, he actually scans before even talk about anything. So they need to understand that it's not scary. And once they've seen ultrasound and they touch the probe, it's way easier for them to understand the bit of physics that we do want them to know, all of the movements. It's really hard to explain fanning or tilting or rocking when you don't know how it feels like. So we get them to the clinic first, and then we give them some theory, and then we throw them back to the clinic, and we actually do the protocols. So it minimizes all of the uncertainty and all of the boring stuff because they already scanned before they even start talking about it, which we found very, very helpful.
What I found with teaching is the death by PowerPoint you'll find in so many ultrasound programs is useless. And by giving someone an ultrasound probe and letting them find the bladder, and everyone in the world can find a bladder. So there was a difficulty a little bit this morning, but somebody had a wee and then lost all the fluid. But bladder is so easy. And by just showing them how it's used and they get their hands on it for a bit, then you can throw in the physics and some of the more deep concepts, and they'll get it instead of just here's a bunch of videos. And then when you get here, we're just going to have 1-to-8 ratio. I'm glad you said 1-to-4 because in the college, our college remote and offshore medicine, 1-to-4 is mandatory. There's just no variance from that whatsoever. And it's interesting that you found the same ratio.
For me, my first exposure to ultrasound was in a military hospital it was during summer after my first year. And what I did was just took the ultrasound without a doctor next to me and just tried it on the patient and saw some things, tried to interpret them. Then I start researching on it. Like it's a skill that you need to get your hands dirty a little bit. This is how it grows. It's like cooking.
In Turkey, do you have ultrasounds on the ambulances?
No, you don't, but you do have it in every ER, just like how it's supposed to be.
I mean, just hearing you guys talk about the getting into the ultrasounding straight away it makes so much sense. I mean, I think the key foundation thing to learn is to be able to have your home, right? Your home concept, and get your internal picture in your mind of what you're looking for. And then once you do that, then you basically can be let go on your own. That's one thing that I loved about the way that we were taught about initially in my agency, and I would have liked it to have been a bit more, how CoROM's APUS program is where you just get a bunch of reps in and you just drill it into you. But we didn't really get that opportunity. What we had was we were given an anchor image, a home, and we were just let out. And so really there was a real big gap between me being able to see an anchor image with someone else showing me and sort of getting some coaching through finding it myself to being confident and being able to find that. That was maybe 50 patients of me just being like, I have no idea what I'm looking at. And part of it is just being able to look at an ultrasound screen and differentiate white noise. It just looks like a little bit of a snowstorm to, oh, that's an organ. That's a solid organ. That's a soft, that's air. And then you stuck it into physics, and it makes so much more sense once you start actually doing it yourself. And, it's the same, like you were talking about with someone having your hand over the probe. When you're lost and you just can't somehow move it, and then someone comes in, takes the probe, moves it exactly, and you're like, that's all well and good, but I have no idea how you did that. I can't recreate that at all. And it just doesn't teach you what you need to learn. And it's the same thing with just finding those, like understanding what you're looking at. For me, that took a lot longer than actually finding it. What am I looking at? I'm just like, why is it backwards? Why is it when I turn left, it goes right? Am I pointing the probe in the right direction? Even just the screen takes so much time to interpret.
For those of you listening in, the reference to home is something that I came up with Quorum, and it's easy to get lost. So when you are trying to do an EFAST or you're trying to find a specific organ and you just get lost in the snow. So my premise is there is a home point. There is a place for you to go back to, which is a starting point. And so for looking at the liver, the starting point is your knuckles are touching the ground. You're straddling the lowest rib. And from that point, you move up, and 95% of the time, even people who are brand new are finding that point. So you guys have picked this up. Is this something that you're going to embrace, or is there a way to improve now that you've seen this for 2 days? How are you guys seeing the CoROM way of doing it?
So when we teach, EFS is just one of the stuff that we teach, because again, we do anatomy and we look deeper into some of the organs and structures. We need to find those home points for the other structures, think for the EFS, it works amazing. Now we need to figure it out when we scan the entire liver biliary system, the aorta, where do we give the students that reference point so they can keep going there? And ideally, when we give them free practice, so there's a tutor in the room just for questions, I would like to have that list of home points on the wall in front of them with what they should find, just let them go. And if they do need some correction, we'll be there. But again, free play is king in that sense. You just need some structure. So I think the home point concept is perfect for that.
I would like very much to see the list when you guys have sorted that out. The two of you are finishing. This time next year, you'll be full-fledged doctors. In 2 years, you'll be a full-fledged doctor. And you're leaving the University of Pavia as medical students. I know you're doing a PhD program, so they can't quite get rid of you yet, but you have a momentum on teaching this, having peer-to-peer. So when you leave, you want to make sure that you have continuity. What is your plan?
So what Jonathan mentioned before, right now, what we're working really, really hard this year on implementing is making sure that the relevant courses put the ultrasound aspect inside their curriculum. So if we're talking about cardiology, for example, the way we see it is you should, a specific amount of hours should be dedicated to ultrasound training within the cardiology course. So instead of spending 6 more hours in class, we can do it in an ultrasound lab where you can teach me pathologies and you can teach me physiology and you can teach me anything related to cardio together with the ultrasound. If you do this for 6 years of med school, and if the medical student starts from the first year scanning with the focus of normology, which is something we love and we picked up in Florence a couple of years ago, if you see 1,000 healthy livers, 1,000 healthy lungs and hearts and everything, by the time you do this for 6 years and you graduate and you go to work in the emergency room or gastroenterology or whatever, you have a crazy advantage over people who did not do that, who did not have that opportunity, whether they come from another city or another country. So that's our main plan, integrating everything into the course curriculum through the professors.
Are you getting receptive professors from the university?
It's a struggle. I think it's especially a struggle because we are students, they are professors and doctors. So the way they see it, we are not equal to them, which in some aspects is correct. But I think, like Jonathan said before, we do have the proof of work. We taught over 400 students of this course overall, which is a course of 800 to 900 students. This year, we're going to have a lot more new students coming in that are going to go under our courses. So it's a struggle. It's for sure an uphill battle, but I'm very optimistic about it. Of course, all of this, we need to thank Professor Brunetti for the help with setting up our shop and helping us in trying to make this course a little bit better.
So in a perfect world, you would have a welcome to the University of Pavia Med School. Here's your ultrasound probe for the next 6 years.
Ideally, yes.
The second best thing is, okay, guys, every other Friday, the rooms are open. We are there. Come whenever. Let's scan, which is what we do right now. If we could have had the rooms for the entire day, amazing. But that's where it's going. So at least you have a space where students can come and practice with some supervision. Even if you're a first year or second year student, why not start earlier, right?
Medicine has some unwritten rules and traditions, and one of them is we have a master, we have a professor who teaches to the younglings, not only the knowledge, also the practical skill. And this is a part of the culture. If we can implement that culture into our faculty, we will make this sustainable. This will continue. We will have, in a way, some successors.
I do think that peer-to-peer still needs to stay in some way, whether it's through the curriculum of the specific courses or as an outside project where you can come and supplement your ultrasound knowledge. Because my first experience was really bad, and after finishing that, I had zero interest in ultrasound. Once I did my clinical rotations in the infectious diseases ward, and one of the residents gave me 10 minutes of explanations and explained everything in a really clear, nice way, I was super into it. And I think that me as a student, I would much rather as another student to teach me and to give me the treatment that we are on the same level, and he knows what I need to know, and he knows where I fall short, and he knows how to explain and bring me the concept. So I do think that peer-to-peer should 100% have a place in one way or the other, talking about ultrasound education.
I mean, so it's been super interesting coming from, we all have extremely different backgrounds in terms of me versus you guys, because I go into this with very limited anatomy knowledge, right? My education is very limited in terms of its anatomy. I don't get to do like cadavers like you guys said you didn't either, but I don't spend a year looking into anatomy. I have major organs, I have major fail points in our body is mostly what we focus on. But just being able to see the way that you guys have developed your anatomy and being able to learn it in 3D space is super cool to watch, because I mean, there's all sorts of stuff with people being concerned about the future of medicine and people not knowing how to assess a patient. And I feel like that disconnect, right, of the new stereotype of a doctor walking into the room, folding their hands, asking you 5 questions, and then leaving and going to order 700 labs on the computer is a genuine concern. And I feel like the place where ultrasound steps in is you get to be able to see and assess the patient, maybe not as, so I don't know how to word it, but maybe not as sort of magically as it used to be in the old days where they said cough and somehow while touching your foot you can tell something about their brain. But there is a real skill to be said to having an actual assessment. It was one of the wonderful things that I learned in Tanzania was the power of continually assessing your patient physically. And I feel like ultrasound is the closest thing we can still get to real physical assessments. And you guys are bridging that gap to, I mean, I see it every day. There's med students that come on my ambulance who do not have those physical assessment skills. And, there's variations between DOs and MDs, but you guys are really making sure that that's still a thing. Especially bring it back to the differences between you guys and paramedics. Paramedics are very much like, is it broken? Is it not broken? It's not what's really going on. And it's cool to see that you guys have that foundation.
I'm happy that you're motivated to continue the peer-to-peer teaching. What I found in 35 years of being an EMS is teaching helped me learn. And it wasn't until I had enough confidence in ultrasound skills and started teaching that I learned a lot whilst teaching. Learned from what my students were doing, learned from my students. I learned a lot from you guys this weekend. And teaching is a way to kind of solidify it in your head.
Yeah, absolutely. I think that, at least for me right now, the main driver for me deepening my knowledge and expanding my ultrasound skills so I could teach them. And especially because we're not doctors yet, so we don't have our specialty set yet. So we're pancakes, basically. We go everywhere and we study a bit, and whatever is interesting, we go a bit deeper. And when you have to explain a concept, you have to understand it, right? You can't just throw words. You need to be able to answer good questions and sometimes go very in depth, sometimes be very shallow if you answer, but you need to have this understanding, this holistic understanding of ultrasound and anatomy, physiology, whatever we look at. So for me, teaching right now is the biggest driver of anything.
My final question for you is this. What advice do you have for the nurse, the paramedic, the doc, who is just starting out on their career and learning about ultrasound?
Get a good teacher. That's 100%. Take your time. I know it's even for everybody in this room. I'm sure that the first couple of times you have no idea what you're looking at and how to read the image. Take your time. Like anything else, it's skill-based. The more hours you put into this, the better you're going to become. And it's a lot of exploration, like Jonathan said. So we started from teaching the abdomen, and once I felt like I'm proficient enough, I started deep diving into other systems such as the neck, for example, and I just read about it. I watched videos about it. I went to the department to learn more, and now I think I'm proficient enough to teach it. So it's all about time and being consistent, I would say.
I would say don't be scared. You can't hurt anyone with the ultrasound. Get your hands dirty.
I think ultrasound is the future. Stethoscopes are looking a little rougher these days. And just do it. If you have 3 minutes with the patient, it's worth it. But don't forget the really important things about ultrasound. Ultrasound is not going to be the thing that saves the patient's life. It's going to be your treatments. So don't forget to do those first. And second, it is not a rule out. It is a rule in. Just because you don't see it doesn't mean it's not happening. And it is a trending measure.
For me, the best tip is just don't, even if you have setbacks, even if you learn something and you try to do it yourself and you don't succeed fighting it, just do it again. Just do it again. Just do it again. Just put in the hours, watch videos online, and just play around with it. Eventually everything clicks, and then you're on your path to do whatever you want with ultrasound, basically.
Well, it's been fantastic to see you this weekend in the course. And it's great to be back to University of Pavia. And thank you for being a guest on our podcast.
Thank you
for having us.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.